Morning, everyone. I think we are all set. We have some audio challenges today, so please bear with us a little bit. But we have a great presentation in hand. Dr. McKay will be joining us today. I want to give a special thanks to the Sanford Burnham Institute for letting us use this auditorium. It is certainly a privilege for us to be able to meet in person here. Our principals of the organization are Bill Lewis, our president, who also does our newsletter summaries, Jean Van Vliet, our director and treasurer, Steve Pendergast. Steve here today? Excellent. Steve is here today. He does the great job with the newsletters and is our secretary. Bill Manning, behind the camera in the back, our director and videographer. Myself, Aaron Lamb, director and facilitator, and John Tassi, our webmaster. And of course, there's a lot of members out there, not just in San Diego, but around the country, if not even farther these days. And everyone is a volunteer. You can be too. Do we have any newcomers today? You can raise your hand. Thanks for coming. Were you two given a newcomer packet as you came in the door? Great. If you could make sure to hand in the cover sheet. We have cover sheets this month, Bill? Yes, excellent. That packet that you received has a lot of information in it, a lot of articles and links to references to articles and booklets to help you get informed on treatment options available to you. And you'll also be getting a welcome call. Let me move this a little bit more. A welcome call sometime in the next week or two from Bill or Jean, just to connect one-on-one with you and see what assistance the organization might be able to provide. All right, a lot of you are familiar with this, but especially for the newcomers, we want to go around, show a show of hands of how long people have been seeking treatment for their prostate cancer, or really since diagnosis, and what kind of treatment options they've had. It's a great way for you to be able to see, the level of experience in the audience, as well as, look around when we raise our hands for the different treatment options. If you yourself have a question about what treatment you might be considering yourself, that person that raised their hand is an opportune person to go up and ask questions of later. So we've seen two guys here that are here for the first time. Who else has been recently diagnosed? All right, a couple people here. How many have had PCA for less than 1 year? Go ahead and raise your hand. All right, our newcomer, yeah. How about 1 to 4 years? Yeah, starting out in our journey. How many 5 to 10 years? Okay, quite a few still. 11 to 15 years? Yeah, quite a few. And longer. Gene, how many years?
21 now.
Mike?
17.
17.
22.
22. 26. Especially for you newcomers, realize, this is a disease for which you have a long life ahead of you. As it said in the first sentence, first slide there, prostate cancer is 2 words. It's not a sentence. How many have been under active surveillance? All right. How many have had surgery? Radiation? ADT or hormone therapy, right? Chemotherapy, still a few of us. How about new treatments, whether it's focal or immunotherapy, Xofigo, Pluvicto? Yes, all of the above for Gene, yeah. He is the #1 reference for, not just guinea pig, but definitely reference for your questions. How many people have had reoccurrence? Treatment, and then it came back. Yeah, that's why many of us are here. And how many are undecided on their future treatment? A lot of us would be raising our hands. Yes, that's right. I want you all to remember that we are on Instagram. You can find us on Instagram.com/IPCSG3. A lot of posts going up there, and we are approaching 600 followers. I'd love to see that over 1,000 before the end of the year. I think we're leveling off a little bit, and we need the word to get out a little bit more. This really helps us get our page in front of a lot of eyes, not just in San Diego, but around the country. Now, our support to you comes in the way of our website, ipcsg.org. We also have the YouTube channel, Prostate Cancer Support, where you can find all the videos from our prior meetings. Most of you, or all of you, should be getting an email with the newsletters every month. Those have a fantastic selection of new articles, cutting-edge research, as well as the write-ups of the prior meetings, and something to keep a smile on our face once in a while, too. And of course, there's the monthly meetings, the third Saturdays of every month. We won't have a meeting in December, but wish everyone a happy holidays during that period. Pardon me. Yeah.
I don't see the library on the list, but
I'm sorry.
He's our librarian, and we have a new book in the library following up last month's description of Dean Hall swimming the Willamette River in Oregon. He wrote a book, and so I picked it up and read it. It's wonderful. It gives you a different flavor, and it'll be in the library from here on out.
Excellent. Yeah, for those of you that missed the talk last month, Dean gave a very inspiring talk. Quick question from the audience here?
Could you please go back to the previous slide just for a brief moment?
Sure. Yeah, and I apologize for not introducing Bill Bailey. I keep on forgetting to add him to the slides, but Bill has been, a wonderful help, especially to me. He actually was one of the people that I clued in on as having a very similar, journey that he undertook. At the very first meeting that I joined, he was kind enough to share details of his journey, and also as a bike rider and so forth, I just, was like, all right, I see Bill. He's a few years ahead of me. I certainly have a clear view of how I will be in a few years, and it really took a lot of stress off of my mind. Other support to you, and this is another great slide to take a picture of with your phone right now. We wanted to emphasize the fact that you can get a very low-cost PSA testing if you do run into any kind of difficulties or expenses trying to get those PSA tests yourself. I know that I've been pushing it at work before I left work this past week, and a lot of people came back and said, my doctor just won't even approve it. And so, this is a great way for you to take matters into your own hands, very inexpensive.
And it's actually only 21.
It is 21, but I think it was, wasn't there like an extra blood draw charge, and that's why I listed it as 30. Okay, I will change it to 21, yeah. All right. And someone also recommended the Promise germline DNA saliva testing. There's the link there that can help you get a genetic test to see whether you have any markers that would make you predisposed to especially one type of treatment or another. That's a very important thing. And the YMCA has the Livestrong Prostate Cancer Therapy exercise program. I believe it's actually free for us to join if you are suffering from cancer and need that extra help in maintaining your physical strength, which is definitely very important while you're on ADT. We do have, sorry, I listed this as an upcoming meeting, but obviously this is an upcoming meeting for UCSD. Bill and I attended last year, as did a few others in the audience, and this is a fantastic program, and I encourage everybody to attend. This year it is expanding to 2 days, February 9th and 10th. This is at a very nice facility that UCSD just opened downtown on the corner of Park and Market. Great way to get there is by the trolley. It's just, I think, a 2-block walk from there. And you're going to hear a lot of great presentations from, I think, pretty much everyone in the UCSD system that deals with prostate cancer. I'm looking forward to that one myself. And we do need volunteers. We need people to suggest and recruit new speakers and to share your experience. We had a fantastic roundtable a couple of months ago, and we obviously could not do that without volunteers willing to share the details of their journeys. I also, in particular, need a volunteer to run this meeting on January 20th. I will be out of town the end of January, and I really would appreciate it if somebody could volunteer, especially today before we leave. Come up and talk to me. It's not that hard of a job. I'll write up all the slides for you and walk you through it. It's not hard, but man, I would appreciate it. And you can always contact us, www.ipcsg.org. The phone number, the hotline phone number is there as well. Now, I'd like to remind everyone of our support group purpose. We share patient-focused experience on becoming your own case manager through informing, networking, and caring. We are a group of experienced participants. We are not medical professionals, and any sharing by anyone or of our group may not be a substitute for your medical counsel. And we do need our support. Can I get a couple of volunteers to pass around our donation baskets, please? We are a 501c3 nonprofit organization. Donations are tax deductible. There's no medical or religious affiliations. Our largest costs are our website, advertising, mailings, being able to bring you some of these remote speakers. Please do consider making a donation. Think about the amount of time that you get to spend asking the questions burning in your mind versus how difficult it can be to get in to see some of these doctors. And we certainly do appreciate it. If you don't have cash with you today, you can always make a donation online via PayPal on the website, or send a check to the address you see. And the address is also available on the website. For our upcoming meeting next month, we're going to have a talk by Dr. San Denmead, Professor of Oncology at Johns Hopkins. He's going to be speaking on bipolar androgen therapy, and that is on Saturday, the 18th of November. However, for today's meeting, we have Dr. Rana McKay, professor, medical oncologist of UCSD Urology, and she is joining us remote, as you can see. She's going to be speaking on novel therapeutic strategies for patients with advanced prostate cancer. Dr. McKay is a board-certified medical oncologist who specializes in treating people with urogenetical cancers, including bladder, kidney, prostate, and testicular cancer. Dr. McKay leads a multidisciplinary prostate cancer clinic focused on delivering advanced cancer care through a coordinated team approach. And as a personal thank you, she's been the best in my treatment because my PSA is 0 after her treatment. So now, we'll need to hold all questions to the end. We're having some slight audio issues today. Dr. McKay, if you want to go ahead and start sharing your screen. Basically, we'll be able to hear her, but she will only be able to hear us when I'm running around and we ask the questions through my phone. So with that, Dr. McKay, please take it away.
Well, I apologize for not being able to be there in person. I would have absolutely loved to be in the room with you all, talking and chatting and connecting. I'm actually at the European Society of Medical Oncology meeting that's in Spain this weekend. There'll be a lot of new data presented, a lot of interesting data about the forward projection of lutetium PSMA and other really exciting materials that hopefully I'll come back at a separate time and present all that information to you. But we'll dive in talking about novel therapeutic strategies for patients with advanced prostate cancer. And I know that it looks like next month, Sam is going to come and present on bipolar androgen therapy, and certainly we'll include a little bit of that in the context of this talk, talking about novel approaches in prostate cancer. All right, so first I'll kind of go through the different clinical states of prostate cancer. prostate cancer, as you all know, is a very common malignancy. 1 in 8 men develop prostate cancer sometime in their lifetime. It's very, very common. The majority of prostate cancers are actually found to be localized in nature and cured with local therapy. Some patients develop a biochemical recurrence after local treatment, and they can still potentially be cured with radiation and hormone therapy. But there is a subset of patients who then go on to continue to develop a disease recurrence with either a rising PSA and may eventually develop metastases. And sometimes some individuals develop hormone-resistant disease. There are a subset of patients who develop metastatic disease right at diagnosis. And it's probably about 10% of the population of patients who have metastatic disease come into metastatic disease without previously having localized disease. So there's been a lot of forward movement with regards to the treatment of prostate cancer. We all know the backbone of systemic therapy has been hormonal treatments, but that has really evolved since the initial studies that were conducted in the 1940s to include many treatment options that are all listed here on this page. Surgery, radiation, integration of stereotactic body radiation, and lots of systemic therapies, which have now entered into the treatment landscape for people with advanced disease, including hormonal treatments, chemo, immunotherapy, radioligand therapy, and targeted therapy. And really, we're utilizing these treatments across the disease spectrum. Many years ago, we used to save all of the treatments until people developed castration-resistant disease, and everything before the very end of this curve was all pretty empty. But now we're realizing that earlier utilization of many of these treatments has actually been associated with life prolongation. So we're going to dive in, talk a little bit about the advances in metastatic hormone-sensitive disease, and then we'll talk about some of the key more recent advances in castration-resistant disease, and then we'll spend a bit of time talking about novel therapies and clinical trials. So the treatment landscape for metastatic hormone-sensitive prostate cancer really began to change in 2015. So prior to 2015, the backbone of therapy was just hormone therapy alone. And as long as people were responding to their hormone therapy, that was really all that we did. We didn't really escalate treatment for individuals until they developed castration-resistant disease. And in 2015, the results of 3 studies were reported that asked a very simple question. The simple question was, well, we know people live longer when they get chemotherapy and they have hormone-resistant disease. Why not utilize that drug earlier? Why are we waiting until people progress before we use that drug? Why not use it when they first develop metastatic disease? And the results of those studies were resoundingly positive, with significantly prolonged overall survival with early use of chemotherapy. And that those studies actually catapulted us into a series of other clinical trials that began to ask that same question. So we know abiraterone makes people live longer when they have hormone-resistant disease. Why not use it earlier? Why not use it for hormone-sensitive disease? So the Stampede and Latitude trials explored that question and did in fact demonstrate that, yeah, we make people live longer when we use Zytiga or abiraterone earlier on in the treatment landscape. And Stampede was a very interesting study because Stampede included a very heterogeneous, meaning very diverse patient population. The people that were enrolled in Stampede were not only people with metastatic disease, but it included people with localized high-risk disease. And the use of abiraterone was tested across the spectrum. Additionally, in 2018, results from Stampede and the HORAD trial asked another question of, well, what about treating the primary? We know that some patients present with metastatic disease and they've never had their primary prostate cancer treated. They've never had their prostate either resected or radiated. And 2 studies looked at answering that question. One was one of the subarms of the Stampede study. The other was from the HORAD trial. And those studies asked the question of, well, if we radiate the prostate, even when people have metastatic disease, even when the cancer has spread, how do people fare? And they demonstrated that people who have low volume disease, meaning very minimal number of metastases, less than 4 or less metastases, and when the cancer hasn't spread to other organs, treating the primary does make a difference for those individuals. This is not to be extrapolated to people who have high volume metastatic disease or disease that's spread beyond 4 spots, but when the disease is confined, treating the disease in the prostate makes sense. And then in 2019, additional studies looked at the androgen receptor antagonist. Apalutamide was looked at in the Titan trial. Arches and Enzamet looked at enzalutamide. Again, asking very simply the question of, well, these drugs make people live longer when they develop resistance. Why not test them sooner? And those 3 studies, Titan, Arches, Enzamet, all demonstrated improvements of overall survival with the addition of ADT with the addition of enzalutamide to ADT. Now we've started building on our armamentarium. In 2015, the standard of care changed. The standard of care became ADT and docetaxel. And these other studies were really not reported yet. And in 2022, 2 additional studies were reported. These 2 additional studies were conducted in part when the standard of care was ADT docetaxel now for metastatic hormone-sensitive disease. And they asked another simple question of why not triple therapy? We know that ADT docetaxel makes people live longer. The old studies demonstrated that abiraterone makes people live longer. The AR antagonist make people live longer. Why not look at triple therapy? Now, these studies were designed before the reporting out of the studies that are highlighted here in 2018 and 2019. And the Piece 1 and the ARASENS study did in fact demonstrate that when we add abiraterone to docetaxel, people do live longer, particularly those individuals with high-risk disease. And when we add darolutamide, which is an AR antagonist, to ADT docetaxel, again, we demonstrated that we improve people's survival with adding that drug. And it seemed to be independent of their risk of disease, whether they had low or high risk. Adding darolutamide to the backbone of ADT docetaxel improved outcomes. So there's been a lot of advances of therapy escalation for metastatic hormone-sensitive prostate cancer. And these are sort of just to give a highlight of the updated kind of NCCN guidelines of preferred treatment strategies for people with metastatic hormone-sensitive disease. No longer is it really standard of care for people to do ADT alone. I think when we're doing ADT alone, when people have metastases, we are talking about, okay, what's the reason? What's the rationale for doing ADT alone? Is there a side effect issue? Is there a comorbidity issue? Is it what's the issue? Because all of the data would suggest that actually adding something to ADT for the majority of patients is associated with improved survival across multiple studies, not just one trial. Multiple trials have demonstrated that. So we'll shift a little bit, and I want to kind of share with you, this is the top line data from those studies that I had highlighted. I want to make sure that my video isn't blocking my screen here. So a lot of data here lumped up into one slide, but on the top part of the slide, we look at the hormone therapy studies that looked at ADT plus an additional hormonal agent, whether that hormonal agent be abiraterone in Latitude and Stampede, whether it be enzalutamide in the Arches trial, or apalutamide in the Titan trial. Adding one of these drugs to hormone therapy when people have metastases and they're hormone sensitive decreases the risk of death by up to 40% compared to ADT alone. That's dramatic. Additionally, when we look at triple therapy from Piece 1 and from ARASENS, when we add one of these hormonal agents to the backbone of ADT and docetaxel, we decrease the risk of death by 25 to 32%. So these are really practice-changing data about escalating therapy for those individuals with metastatic disease. Okay. So lots of clinical trials are on the horizon. Lots of clinical trials are on the horizon that are going to further impact the treatment landscape in metastatic hormone-sensitive disease. Some of these studies are actually going to be presented here at ESMO. Keynote 991 is going to be presented here at ESMO. But some studies include the Aranote trial, which is looking at darolutamide alone without chemotherapy. This trial currently is being conducted outside the U.S. because, again, the control arm this is not an appropriate control arm for a U.S. population. The Capitello study is looking at capivasertib. It's a AKT inhibitor, particularly works in tumors that are PTEN negative. This is a molecular finding that can be present within the tumor. We know that tumors that lose PTEN is a tumor suppressor. It shuts down the tumor, and when the tumor loses that protein, it can be associated with a more aggressive form of cancer. And so this agent is being tested particularly in those tumors. PSMA addition is something that I think we're all on the lookout for the results of this study. This study is looking at what's the role of lutetium-617 for people with metastatic hormone-sensitive prostate cancer. Right now, this agent is particularly being used in the refractory setting after chemo, after hormonal agents. But this study, which has completed accrual, and hopefully we'll see data within the next year, is looking at the role of this agent much earlier on, when people first get diagnosed with metastatic hormone-sensitive disease. There are a couple of studies that are looking at the role of PARP inhibitors that impact the way the DNA repairs itself inside the tumor. The Amplitude trial and the TALAPRO-3 study are looking at the role of these agents in the metastatic hormone-sensitive setting. So again, before somebody's developed castration-resistant disease, when they're newly diagnosed with metastatic disease. The Cyclone-3 trial is also being conducted in a population of patients that's high risk based off of charted and latitude criteria, and is looking at a drug called abemaciclib, which is a CDK4/6 inhibitor, which has a pretty novel mechanism of action. And we anticipate results from this study in about 2 years. We're going to go through some of the Cyclone data and how abemaciclib works, because it's a pretty, it's a drug that has made tremendous headway in breast cancer, and we'll talk about its potential in prostate cancer. So just a little bit about the cell cycle pathway as we're talking about abemaciclib. So the cells are very, their cell division is very regulated. So usually cells in the body, when they're not in the state of dividing, are in this G0 state where they're kind of arrested, they're kind of, quiescent, they're not getting ready to divide and, make a daughter cell, if you will. There are several steps to the cell cycle pathway when a cell has a trigger point to say, okay, I'm going to enter in and, no longer just be resting, I'm going to get ready to divide. And there's four major steps. There's a growth phase, then the cell makes its DNA, it replicates its DNA, getting ready to make a separate cell with another copy of DNA in that separate cell. Then it grows a little bit more. And then finally, once it's gotten to the right size and it's replicated its DNA, it divides. It divides into 2 cells. And this process is highly, highly regulated inside the body. And this step where the cells go from just growing to making their DNA is super regulated. That G1 to S transition is heavily, heavily regulated. And in cancer cells, as you can imagine, because cancer is a disease where cell growth is unchecked and cell progression and division is unchecked, this step going from G1 to S is these proteins that are involved in this kind of regulation step don't work well. They don't work well, and cells basically can go into the process of cell division in an unchecked fashion in cancer. So there have been cell cycle inhibitors that have been developed to block this pathway, to block the growth and the synthesis of DNA, to basically prevent a cell from proliferating. And some of the early studies of these agents, when they were still kind of coming into practice, there was pan inhibitors that inhibited everything in this pathway. And they were actually quite toxic and never really made it into the clinic. But the science got more robust, and we got better at refining these drugs and finding which are the two critical pathways, particularly CDK4 and CDK6, and developed better drugs to block this pathway that aren't toxic. And so abemaciclib is one of these drugs. Abemaciclib is a CDK4/6 inhibitor. And this drug has already demonstrated that it makes people live longer when they have a hormonally driven tumor, particularly in breast cancer. So in breast cancer, this drug has 3 separate indications because it has prolonged survival when given with hormonal therapy. And now we are trying to replicate that data in prostate cancer. So there is a large clinical trial called Cyclone-3 that is currently enrolling patients. It's just about done. It's going to finish enrollment by the end of this year. This trial is looking at abemaciclib given with abiraterone versus placebo with abiraterone for men with high-risk hormone-sensitive metastatic prostate cancer. So this drug is taking the standard of care. Everybody gets the standard of care. There's nobody that doesn't get treatment, and half of the patients get abemaciclib. And the primary endpoint here is delaying the time to progression. Key secondary endpoints will look at overall survival. And I think this study will be critically important to helping answer the question of what's the role of abemaciclib. But there's a significant amount of rationale, and the road has already been paved in the breast cancer literature. And there's a couple of different CDK4/6 inhibitors that are out there. Abemaciclib is likely the best-in-class agent associated with the best tolerability from the data that we see in breast cancer. I'm going to highlight another study that's important. I told you all about the role of radiation therapy to the primary tumor for people who have low-risk prostate cancer. So those individuals who have less than 4 or less metastases, and still have their prostate intact, their prostate hasn't yet been treated, and they have metastatic disease, we have demonstrated the addition of radiation for those individuals does improve their survival. But what about for individuals who have higher risk disease? What about individuals who have more than 4 metastases? What about for individuals who the cancer has spread to other parts of the body, maybe even organs or other parts of the body? That is newly diagnosed, metastatic hormone-sensitive disease. So this study is looking at, well, what is the role of radiating or even doing surgery on the primary with the addition of standard of care treatment? That's what SST stands for here. It's systemic therapy, systemic standard therapy. What's the role of adding radiation and hormonal or radiation or surgery to the standard of care for people who present with newly diagnosed metastatic prostate cancer with their prostate still intact? The primary endpoint here is overall survival. This trial is currently accruing patients. That's going to answer a very important question, building off of the data that I had shared with you earlier about the STAMPEDE study and the HARAD trial, which demonstrated a benefit of this approach for low volume patients, for low risk patients. All right, so we kind of went through a little bit as what are the recent happenings in metastatic hormone-sensitive prostate cancer, some of the recent trials that are going to be changing the landscape over the next couple of years, and we eagerly await those results. We're going to shift a little bit now and talk about metastatic hormone-resistant prostate cancer. First, I'm going to go through and highlight the lutetium PSMA data and some of the PARP inhibitor data, and then we'll talk about some additional clinical trials of some novel approaches. And I'll just highlight here, I know this can be overwhelming looking at this data. Our approach for how we strategize different options in the metastatic CRPC setting is largely dependent on what are the different types of drugs that tumor has seen and been exposed to help strategize what to do next and how to ensure that we maximize the benefit of any therapy, minimize the risk of resistance. So my plan is always, how can we come up with strategy A, B, C, D to treat any given cancer and maximize the number of different drugs and combinations that we have when we are treating any given patient with a therapy, and how can we add to this list? That's always sort of the name of the game, okay? So let's talk a little bit about radioligand therapy. I'll just start by giving an overview of radioligand therapy. So what is radioligand therapy? Radioligand therapy, as the name implies, is there is a radioisotope that emits therapeutic radiation that can cause damage to cells and cause the cells to die, that is linked to a targeted ligand that binds selectively to whatever it is that that target is supposed to bind to. So you've got a target, a linker, and a radioisotope. And there could be different targets, there can be different types of linkers, and there can be different types of isotopes, okay? We're gonna go towards the tail end of the radioligand section. We'll talk a little bit about just even a broader approach for conjugated therapies, where you're linking something to something else, okay? So a little bit about lutetium PSMA 617. What is it? You've probably heard a lot about it. Many of you all in the room may already know exactly how this drug works. This is a beta-emitting radioligand that's conjugated to a small molecule that binds to PSMA. When that compound binds onto PSMA, which PSMA is prostate-specific membrane antigen, it's a cell surface receptor that's involved in folate uptake that's found on the surface of prostate cancer cells. It's not the only place that it's found. It's a misnomer. Even though it's called prostate-specific membrane antigen, it's actually expressed on many other cells in the body. There's some uptake in the liver. There's some uptake in the neovasculature. There's uptake in the salivary glands. There's uptake in the kidneys. So it's a little bit of a misnomer. But when a compound binds to the PSMA target, the and two areas kind of bind together. The two receptors dimerize, meaning they link up together, and when they dimerize, they get engulfed into the cell. And then now what you've done is you've basically introduced the radiation into the cell, almost like a Trojan horse. You've brought the radiation now into the cell, and the radiation now can damage the DNA that's inside the nucleus of the cell. And when the DNA gets damaged to a certain degree, it can cause the cell to die. And additionally, around this cell, there's other cells. So in addition to killing the cell that it enters into, there's a bystander effect, because there can be some radiation that scatters to some of the surrounding cells. And this drug was FDA approved because of the results of the VISION study that we're going to go into in patients who have received a prior AR agent and received prior chemo. And on Monday evening here at ESMO, during the presidential session, we're going to hear the results of a study called PSMA-4 that is going to be the use of lutetium prior to chemo. So our hope in the future is that the label is going to expand beyond just post-chemo into the pre-chemo setting, but obviously time will tell. So here's the design of the VISION trial. VISION randomized patients to receive either standard of care, whatever that may be per their doctor, excluding chemotherapy and other radioisotopes or investigational drugs. They were randomized to receive lutetium given IV every 6 weeks for up to 6 cycles versus just the standard of care. And this study did demonstrate a statistically significant improvement in overall survival compared to those that were just standard of care. I want to highlight for those patients who went on this trial, they needed to have PSMA positive disease in the absence of PSMA negative disease on their PET imaging. So they had to have at least one PSMA avid lesion with uptake greater than the liver on gallium-68 imaging, and no PSMA avid lesions, either in the bone or their soft tissue, that you can kind of see here. So of the over 1,000 patients were screened for the study, about 13% did not meet the PSMA PET criteria. And these are the dramatic PSA response curves that we see. So about 46% of patients who go on this regimen will have a PSA 50 response, meaning a decline in their PSA by at least 50%. 33% will decline their PSA by about 80%. And there are a subset of patients, you can see this portion of the curve here where the numbers are going high. There's about a third of patients who do not respond well to this therapy. Their PSA goes up despite the treatment. And so we're actually trying to figure out how can we better predict who's going to be a good responder and not so great responder. And there's been some data already that's being developed and more to come. Some data thus far that's been looked at, has been using the baseline PSMA to decide, do various things on the baseline PSA associate with better or worse outcomes. And one of the strongest parameters that seems to be associated with response is SUV mean. SUV mean is not something that's typically reported on a PSMA PET report, and it's not something that a radiologist calculates easily. But out of a lot of parameters, that did seem to be a good predictor. SUV max was actually not a good predictor. That is what is reported a lot of times on these PET scans. You see what the SUV max is and you get a number. That's not a great predictor of how people are going to do long term. Other things that were looked at were, where are the sites of disease? So did they have uptake in the bone? Did they have uptake in the liver? Did they have uptake in the lymph nodes? And presence of uptake within the liver was associated with, worse response to the treatment. This is kind of a double negative because this says absence of PSMA positive lesions in the liver. So a lack of liver lesions was associated with a better outcome. That's why you see an S with a plus. People who seem to do really the best seem to do those people that had lymph node metastases. And then you can see the SUV mean data down here on the bottom. So there's lots of PSMA radioligands that are being developed, and there's lots of different settings that they're being developed in. And there's lots of different ways that these drugs are being looked at. So as I told you, there was a radioligand, there was a radioisotope with a linker and a target. And these right now all target PSMA, but there's a couple of different ways you can target PSMA. You could target it with a small molecule, or you could target it with a monoclonal antibody like J591. You could be linked to an alpha emitter, or you could be linked to a beta emitter. So 617 and INT, which is being tested in SPLASH, are beta emitters, but there are alpha emitters that are being looked at. So you can see here, actinium 225, that's an alpha emitter. So, and these trials are being conducted across the spectrum. So there's a ton of trials being conducted in red here in the hormone resistant setting, but there are some studies being conducted in the hormone sensitive setting here in yellow. And there's even a study that's being conducted in Australia with lutetium prior to surgery. So lots of excitement. So just another word about selective radioconjugates. So we've talked about radioligand therapy, but the same concept of carrier, linker, payload, or like target, linker, payload, is being utilized for novel drug development across oncology. So there's lots of different kinds of carriers that target different kinds of things. I gave you two examples of a small molecule inhibitor with 617 and an antibody with J591. There can be different kinds of linkers that break apart in different environments where the payload can be released into the cell. So there's different ways that you can get the payload into the cell depending on how the linker is designed. And there's different kinds of linkers. So we talked about nucleotides. We talked about, an alpha particle or a beta particle, but there's other linkers too, or there's other payloads too, like chemotherapy payloads where we can deliver targeted chemotherapy. Those are called antibody drug conjugates. There's a handful of them that have already been approved in several GU malignancies, and there's a ton that are being developed in prostate cancer. So I think this is really exciting way to deliver more targeted therapy to cancer. All right, I'll showcase here. We were the first center in the region to actually have lutetium PSMA available for our patients. It's readily available. There's really very limited wait time to receive it. I think our nuclear medicine team is getting people in pretty readily, kind of within a week of their consultation for evaluation for lutetium PSMA. So I think this is right now, particularly for individuals who have metastatic hormone-resistant prostate cancer, have already seen a hormonal agent, have already seen chemotherapy. This is the current indication, but the hope is in the future this will change. My suspicion is probably sometime over the next 6 months, the label may get expanded. Okay. All right. We're going to segue into PARP inhibitors a little bit. And what we're learning about PARP inhibitors is that, well, what are PARP inhibitors? PARP inhibitors basically are drugs that impair the way the cancer cells repair their DNA. And they seem to be particularly effective for tumors that have alterations in the way they repair their DNA. And in prostate cancer, the rates of tumors having alterations in the way they repair their DNA for people with advanced disease, metastatic disease, is about 30%. And of those 30%, I shouldn't say of those 30%, of everybody, about 10% are hereditary alterations. In the localized setting, the risk of hereditary alterations ranges from as low as 2% to as high as 6 to 8%, depending on the risk of disease. So there are indications for people with prostate cancer to do genetic testing, particularly people with advanced disease who may have metastases. And there's two kinds of genetic testing. There's genetic testing to look for a germline mutation, look for something that's hereditary, that's passed on from mom or dad to a child, and or it could be something that's actually found in the tumor that's just happens because it's a tumor, not because of a hereditary phenomena. So germline mutations are hereditary; they're inherited, whereas somatic mutations are acquired. They're not passed from parent to child. So, on this table, kind of try to demystify a little bit what this biomarker testing is. What do we mean when we say germline? What do we mean when we say somatic? And who should get what? So anybody that has high risk, localized, recurrent prostate cancer or metastatic prostate cancer should undergo germline testing. The reason to do it is it's prognostic, it's predictive, it can inform how somebody's going to respond to a therapy. It can inform screening for other cancers in that individual. So if somebody has, a BRCA alteration, they may be getting mammography to screen for breast cancer. If they've got a Fanconi alteration, there may be a path for screening for pancreatic cancer and colorectal cancers that's more intensive than what a normal individual would do. Additionally, it can inform cascade testing. So BRCA alterations that occur in men that make individuals at risk of prostate cancer, they can be found in women with breast cancer. So it's important to understand that. And, if there's an individual with prostate cancer that meets the criteria for testing, to think about doing the testing. And then somatic tumor testing, this is testing the tumor. It's not testing your normal cells. It's testing what's in the tumor. And what's in your normal cells is also in the tumor, but also extra stuff is in the tumor. And anybody with metastatic disease really should undergo somatic tumor profiling. There's a couple of ways that we do that. We can, I thought I included it here, but we kind of go through some of this. So that could be done either via a blood test or by looking at the tissue. Okay. So here again is the analysis looking at the rates of hereditary alterations in men with advanced prostate cancer. And the rate in people with metastatic disease is about 12%. And like I said, localized disease about 2 to 6%. And the most common alteration is BRCA2. Okay. And then again, the why, who, when, and how to test for germline testing. So, again, this is kind of things that we kind of talked about, but it's here on the slide, so you have it for your reference. These are the key genes to test for, though. At our institution, we do test for an expanded gene panel of over 100 hereditary genes. All right, so one of the reasons to do this kind of testing is because this kind of testing for people with advanced prostate cancer can open up the door for additional treatment options for them. So there was a study called the Profound trial that looked at a drug called olaparib, which is a PARP inhibitor. And it took individuals who had a alteration in the way that their tumor repairs their DNA. It's about 15 different genes that were looked at. And they randomized patients to receive the oral drug olaparib versus either abiraterone or enzalutamide at the physician's choice and the patient's choice, after they'd already progressed on one of those drugs. So if they got Abi, they would get enzalutamide on the trial. If they got enzalutamide, they would get Abi on the trial. And this trial demonstrated that particularly in individuals that had a BRCA1/2 alteration, that the use of olaparib significantly reduced the risk of death, made people live longer, delayed the time to progression. Okay. Cohort B of this study, so cohort A was particularly individuals with BRCA1/2 ATM. Those were the people that really seemed to benefit, and more specifically the BRCA1/2 people. The other alterations group here, this cohort B, included an admixed population of patients with CDK12 mutations, CHEK2 alterations, Fanconi gene alterations, other different kind of alterations. And while there was no OS benefit that was seen in cohort B, the study wasn't really powered. Cohort B wasn't really powered to demonstrate an OS benefit. The sample size is small. I think what we see with cohort B is that the effect size, meaning the degree of benefit we would expect to glean from olaparib, is not as large as the degree of benefit in somebody that's got a BRCA1/2 alteration. It's not to say that there isn't a benefit, it's just not as pronounced. Okay. Additionally, there was data that were presented on another drug called rucaparib from the Triton-3 study, and these data were recently reported earlier this year, looked at rucaparib in people who had already progressed prior to or after receiving a drug like abiraterone or enzalutamide. This study was conducted in patients who had not seen prior chemotherapy, and patients were randomized to receive rucaparib or patient physician choice of either chemo, abiraterone, or enzalutamide. And the primary endpoint of the trial was progression-free survival. And this study did demonstrate that the addition of the use of rucaparib in people who had a alteration in BRCA1 and 2, that's what we see in this panel B here. These are the BRCA altered people, resulted in a significant improvement and delay in the time to progression. When you look at the ATM group at the bottom, the benefit is really not as pronounced. The people who are deriving benefit are those patients with BRCA1/2 alterations. The other really important finding from this trial was we struggle in the clinic with determining, well, when's the right time to use a drug like this for somebody that's got an alteration? Do you use it pre-chemo? Do you use it after chemo? How do you sequence it? This trial did include chemotherapy in the control arm. And what we also saw in this trial, that actually using a PARP inhibitor earlier before chemotherapy is better than going to chemotherapy. And so I think in my practice, I think the preference is to try to do the PARP inhibitors preferentially before chemotherapy if the disease allows, and if they've got a BRCA1/2 alteration. So this is kind of things to consider. I think these data have been really important. Now, there have been a series of additional studies that tried to look at PARP inhibitors combined with hormonal agents. And these trials were conducted in unselected patients. So they were conducted saying, you know what, PARP inhibitors seem to work in the subset that are mutated. There's some preclinical data when we use these drugs in combination with the oral hormonal agents that they may work better when used together. And so there was a series of clinical trials that looked at PARP inhibitors with the oral hormonal agents to see if they actually improved outcomes for patients. Now, there's been a lot of controversy in this space about what to specifically do, but I'll give you kind of the take-home message and what the FDA has decided, which I think makes a lot of sense, is they have approved these combination therapies, particularly in individuals who have BRCA alterations. That's where we seem to see the benefit. In the unselected population, we don't really seem to see the benefit. The TALAPRO-2 study did extend the approval to other HRR genes, but again, all of these trials were done in the first-line mCRPC setting. People who were on these trials had mainly received hormone therapy alone. They had not been previously exposed to Enza or Abi. They were getting those drugs for the first time in the context of this trial. So the data about use of these agents post progression on a drug like Abi or Enza is, it's not zero, but it's limited. There are some select scenarios where it may make sense to do that, but for the majority of cases, using these drugs, use of these drug combinations has been kind of restricted to the frontline mCRPC setting, particularly in individuals that are BRCA mutated. All right, so now let's delve into clinical trials. The reason I spent a little bit of time on that is honestly that's been for people with advanced disease, the most relevant phase 3 data that's been presented that could potentially impact outcomes. So over the last year and a half, that's been sort of the top line phase 3 data in the advanced setting. Okay. So now let's talk about clinical trials. And the first thing that I'll share with you is there's been several analyses that have been conducted that looked at outcomes of individuals who participate in clinical trials. Not even the results of the trials that they were on. Just take a survey of people who get care and participate in a clinical trial versus people who just never never see a clinical trial. People who participate on clinical trials do better. They live longer from multiple different analyses that have been conducted. And there's a lot of reasons for that. But, I think it's important to always think about clinical trials and how they could impact outcomes for individuals. This survey here was conducted of 162 trials, over 100,000 patients that were analyzed from trials that were conducted through the NCI, and looking at the life years gained from individuals that had participated on these trials these were just NCI trials. They were not industry run. They were run through the National Cancer Institute. And if we tabulate just the life years gained from the individuals that participated in these trials, over 14.2 million life years gained. So I think, always at every juncture of the road, whenever your treatment is being changed for one reason or another, always pause and ask, is this a time for me to enroll on a clinical trial? If so, what are my options? What makes sense to me? And you may decide to participate in a trial or not, and that's okay, but it's always good to pause and ask the question, okay? So some clinical trials to highlight. The CONTACT-2 study was just recently reported in August to be a positive study. This is a large phase 3 trial that was conducted in people with advanced hormone-resistant prostate cancer, looking at the combination of cabozantinib, which is a drug that affects the way the cancer cells repair their DNA, with atezolizumab, which is a immunotherapy treatment that turns on the immune system to fight against the cancer. Prior to these results getting released, we were involved in the early phase studies of cabozantinib and atezolizumab, and atezolizumab is a PD-L1 inhibitor. It's a good drug, but there are other types of immunotherapies like PD-1 inhibitors, which certainly in other disease contexts have demonstrated that they've been associated with improved outcomes. So we thought at UCSD, why not use a better checkpoint inhibitor with this combination? Why are we using atezolizumab? Let's test this with nivolumab, which is a PD-1 inhibitor. And so it's very, it's great that contact 2 is positive. We have a study enrolling patients with cabozantinib with nivolumab for patients who have metastatic castration-resistant prostate cancer, where we take this agent that has now, in this, we haven't seen this data. Hopefully, and the data is not going to be presented at ESMO. Hopefully, it'll be presented at GU ASCO coming up in January. But the goal is to try to improve on what we've done with contact 2. So this is an option for individuals that have received prior hormonal therapy. It is enrolling people who may or may not have received docetaxel. They don't have to have received docetaxel as long as they've not received a prior immunotherapy agent. All right, and so this is kind of that original data from Cosmic 021. This was the phase 1 study that actually ended up resulting in the large phase 3 getting done, and now that large phase 3 being positive. All right, another thing worth highlighting is ROR1. So what is ROR1? ROR1 is a receptor tyrosine kinase that is on the cell surface of different proteins, and it mediates signaling through the Wnt5a pathway, which is actually important for cell proliferation and helps drive the cancer stem cell, if you will, and is important in that kind of maintenance of the cancer stem cell that kind of can keep giving rise to various daughter cells, and kind of, it's very hard to kind of get rid of stem cells, quite honestly. And so there have been drugs that have been developed to specifically target ROR1. There's a monoclonal antibody that we have in clinical testing called seramtuzumab. It actually had a name change. Seramtuzumab. There's been multiple companies that have been involved. It was a drug that was developed at UCSD, and they have spun off, and from the monoclonal antibody actually made a antibody drug conjugate that's now owned by Merck. But that original monoclonal antibody is in testing at UCSD. These are what we call a spider plot up here, and these were patients who basically, if you look at the size of their tumors, and things are shrinking at the bottom, so baseline is 0 and things are growing at the top. And these were people that had received seramtuzumab by itself. This was not prostate cancer patients, but demonstrating that utilization of this drug resulted in declines and shrinkage, of their tumors. And there's been studies that have been looked at of this pathway, particularly in prostate cancer, and that inhibiting ROR1 expression in prostate cancer seems to reduce kind of the aggressive cancer cell phenotype. So there's been various studies that have been done. We're in the early stages with this drug in the clinic called seramtuzumab. We're combining it in combination with docetaxel, doing a lead-in with seramtuzumab, then giving with docetaxel, and then continuing with seramtuzumab. This regimen has already been tested in breast cancer as well, with some early promising data, so something to kind of think about. Now, bipolar androgen therapy, I know you're going to get a full, this definitely warrants a full lecture on its own, probably several lectures on its own. I know there's a lot of excitement about bipolar androgen therapy. And so what is bipolar androgen therapy? Really, in the context of people who have been exposed to hormonal therapy for a long time and developed resistance to hormonal therapy, meaning they're on ADT and their cancer has progressed despite the ADT. What bipolar androgen therapy is basically cycling the cancer cell between very low levels and very high levels of testosterone, kind of within a short interval of time. And you're basically making the cells potentially susceptible to additional hormonal strategies when you do this cycling. So here is sort of a picture of a patient who had received his PSA was rising, and had received BAT here, that you could see at the bottom, his pre-treatment, okay? And then when you, after the BAT therapy, kind of stabilized this PSA, after the BAT, went on to receive castration treatment, and then there was a resensitization, things shrank, basically, after, the PSA continued to go down when went back to castrate T. So there seems to be a suggestion that we can resensitize to castration and even AR inhibition with BAT. There was a study called the Transformer study that Sam's going to probably talk to you about next week. Won't spend too much time on this. That took individuals who are progressing on abiraterone that were on ADT, and patients were randomized to receive enzalutamide, and then if they progressed on the enzalutamide, BAT, or they were randomized to receive BAT, and if they progressed on the BAT, enzalutamide. So they kind of had, this reverse sequence. And what you can see in this graphic here, in arm B in particular, the people who went from enzalutamide to BAT, there was a 20% of people that had a PSA response rate. Okay, so you can kind of see here. And then when you look at the red curve of people who went from BAT to enzalutamide, so this is people going from BAT to enzalutamide, the sensitivity to enzalutamide increased. So 77.8% when people saw BAT first, and then they got the enzalutamide, they seem to be more susceptible to enzalutamide than the reverse, if you will. So we do have the Step Up trial opened here at UCSD. That's asking the question a little bit more, looking more into this sensitization to an AR antagonist with BAT. And the Step Up trial is being opened here in partnership with Sam from Hopkins. This is a Hopkins run study that we have open. So it's taking individuals who have hormone resistant prostate cancer and they're progressing on abiraterone. Now, this trial is not really designed for patients who have rapidly progressive disease, or they've got painful metastases, or they've got a history of a blood clot or history of a heart attack or one of those things, a recent heart attack, I should say, just because of the side effects of the testosterone and the risk of a flare response. So people progressing on Abby, they're going to be randomized to one of three arms. Arm A, they'll just go on to continue on their ADT, and instead of the Abby, switch to Enza. So that's one arm. And it's a 2-to-2-to-1 randomization. So there are 30 patients will go into arm A. Arm B is looking at sequential BAT. It's looking at 2 months of BAT and then 2 months of ADT Enza. 2 months of BAT, 2 months of ADT Enza. And the cycling here is independent of PSA. It's just cyclic dosing, 2 months on, 2 months off, 2 months on, 2 months off, until there's some sign of radiographic progression. Arm C is adaptive dosing, where people start on BAT, then depending on what happens to their PSA, if they develop a PSA progression, they go on to get Enza. If they don't develop PSA progression, they stay on BAT, and they continue to be assessed throughout. So if they go to Enza and they're responding to the Enza, they basically can go back and cycle back into BAT. So it's kind of cyclic. So, there's a lot of kind of decision points that are made here, but in essence, it's the PSA that's driving the decision to do BAT or Enza, but everybody starts with BAT. So this study is enrolling, and I think is going to answer a very important question about how can we use BAT to help sensitize patients more to enzalutamide, to an AR antagonist. Okay. And then I'll highlight some other studies. I know we're coming up on, I think we're doing okay, but just going to focus on the time here. So in people who have advanced prostate cancer, they can be at risk of developing alterations in the DNA, in the androgen receptor. The androgen receptor is the most commonly mutated gene in prostate cancer. And in advanced disease, people that have hormone resistant disease, There can be amplifications that are found in 60% of patients. About 5 to 10% of patients can develop splice variants. 15 to 25% of patients can develop AR mutations. So it's very common to see these mutations. Additionally, some of these mutations can sensitize cancer cells to different ligands. So, things that usually don't turn on the androgen receptor start to turn on the androgen receptor, like, for example, steroids or low-dose estrogens, other things. So it's important to be doing genetic testing along the way to see if these mutations have emerged, because that'll impact how we sequence treatment and what drugs we use and when we use them. So that kind of segues into a very nice drug. Well, you're saying, well, if the androgen receptor is the crux of the problem here, why not get rid of the androgen receptor? How do we get rid of it? How do we get rid of it? If it's driving the problem in people that have advanced disease, how can we get rid of it? So there are drugs that are actually being designed to do that. There are drugs called androgen receptor degraders that are being designed to degrade the androgen receptor. So inside the cell, you have something called a proteasome, and the proteasome is, you can equate it to just like your local garbage disposal. So in every cell, there's a garbage disposal, and when there's proteins that kind of aren't doing what they're supposed to do, they're getting old, there's a process where you tag the protein with ubiquitin, and then that tells the cell, up, it's got to go to the garbage disposal, we're done with that protein. So there are drugs that are being developed that are called PROTACs that basically help target certain proteins to ubiquitinate them to get them to go into the garbage disposal. And there's a drug called ARV-110 that's in testing and demonstrated from early clinical trials significant activity, particularly in patients who have these mutations in their androgen receptor that have mutant AR. And these tumors can be quite resistant to hormonal therapy. So at UCSD, we actually have their next generation drug, ARV-766, which is kind of the better version, if you will, of this PROTAC, this proteolysis targeting chimeric drug. And this is in phase 1 testing, but we're pretty far along. The dose escalation has been completed. Much of the dose finding has been completed. We're in expansion now. Right now, we're enrolling patients that have mutations in their androgen receptor. And probably at the end of this year, there will be a cohort that'll open in combination with abiraterone. So these drugs are out there and being developed to better target the androgen receptor. So one of the last studies that I want to highlight, the COMRADE trial. This is a trial that's almost done with enrollment. There's less than 10 spots left. It's been open across the US at multiple sites through the NCI, looking at the combination of olaparib with radium-223. Radium-223 is a DNA damaging radioligand. And as I've told you, olaparib, the way it works is it damages DNA. And we think that there's synergy between these two agents given together. And this trial is almost complete. These were data that were presented initially from our phase 1 portion that's completed and now published, and now finishing up the phase 2. I've told you a lot about genetic testing. We do have an educational intervention at UCSD with a video and some information about germline testing to help kind of improve patient understanding and caregiver understanding about germline testing. So this is something that people can participate in. It's essentially a simple video for those individuals that have not had germline testing done. And I've highlighted again the rates of genomic alterations in the localized setting. 2 to 8% of patients with localized disease have genetic alterations in their tumor. We've conducted a series of trials of hormonal therapies prior to surgery for people with localized disease, and demonstrated that upwards to 30% of people can get reductions in their tumor size by giving the hormonal therapy prior to surgery. So the TAP study, the neo-abi-trubi, neo-enza, neo-abi-enza, we've kind of done a series of studies where we've intensified therapy for patients with high-risk disease, localized prior to surgery. And building on that same paradigm, we've demonstrated that people who actually got this therapy and were able to get a past CR or minimal residual disease, these people have very excellent outcomes. They don't recur. This curve is flat. Not a single person on this when we did this initial meta-analysis, not a single person had recurred that had a past CR or minimal residual disease. And when we repeated the analysis with an additional 70 patients added, I think we had 2 people recur in this group. So, a pathologic response does seem to correlate with improved outcomes. But obviously these studies are small. But I put this up here to highlight this trial called Neptune for people that have hereditary alterations in BRCA1 or 2, giving olaparib with an LHRH agonist prior to surgery for those high-risk individuals. So this, be on the lookout for this. I'll share with you, this will kind of be the ending note here. We have a very multidisciplinary team here at UCSD. Lots of individuals that are involved. It takes a village from urology, radiation oncology, our nurses, our specialists, social work, pathologists, radiologists, really all focused with the patient being at the center of this wheel here. And our goal is to make you all live longer, make you all live better, and make sure that we get you access to the treatments of tomorrow today. That's why we do what we do, okay? You've already heard about the Patient Summit. We're super excited about this event. Register, because last year we actually had to close registration because we hit our cap. But this year we're gonna hopefully have a overflow room and hopefully be able to accommodate everybody that wants to attend. It's a free event, free food, free breakfast, lunch. The day before, for those of you that are interested in, we will have a community think tank. The community think tank is really designed to be a small group discussion, hearing from our patients, hearing from the local community about what matters to you. What are the things that, the things that you think are going to be impactful from a research standpoint. So as we set sort of the research agenda for our program, we are directly walking hand in foot with our patients around where the priorities are. So, we hope that you can participate in this event. It's for anybody and everybody that wants to learn more about prostate cancer. We're going to have speakers from across the U.S., also from here at UCSD. We've pinned down our keynote speaker. Mike Haynes is going to be coming for all of you all football fanatics. He's a NFL Hall of Famer and probably one of the greatest cornerbacks in the NFL. He will be giving the keynote address. He is a prostate cancer survivor and will be able to share his story with you. So lots of advances. It's been exciting taking care of individuals with prostate cancer. Like I said, my job is to make sure we provide well-rounded, personalized care for every single patient that walks in the door and make sure that you have at your fingertips the world's best technologies and treatments to improve your disease. So with that, I will stop. And I'm sorry if I took up so much time. I wanted to make sure that I explained some of these complex treatments to all of you.
Dr. McKay, can you actually hear me? No, I don't think so. Okay.
You can hear me now, right?
Yes, I can.
Okay, hopefully we won't have a lot of feedback here.
One more time. I got to leave that working so that we can hear you. All right.
Who here has a question? We're gonna try to run around and see if this will work.
Thank you. Dr. McKay, I'm a Gleason 9 stage 4 survivor. I'm also a patient advocate with the Southwest Oncology Group, and I noted you referenced your SWOG 1802 study. So one of the things that I'm really concerned about with clinical studies is access. Most people, 60%, are diagnosed after 65, meaning they're in Medicare. 54% of the people in San Diego County are enrolled in Medicare Advantage programs. UCSD is our only outlet here for clinical studies. And if you don't have regular Medicare or insurance with UCSD, you don't have insurance coverage in order to access these clinical studies. And if you're unfortunate enough, like myself, and you've been enrolled in your Medicare Advantage for more than 24 months, no one will sell you a supplemental insurance program for regular Medicare at that point, especially if you've been diagnosed. How do people in that category get access to these clinical studies?
Very good question. And I'm certainly going to lean on probably our patient navigators and Letty Marquez at our team, who's been just awesome. The state of California actually has a law that enables patients, if they are getting care at a facility and that facility doesn't have access to the clinical trial and their insurance provider doesn't, doesn't cover care there, and they have another life-saving option in the form of a trial somewhere else that isn't available by where their insurance is covering their care, they can receive care out of network, out of their insurance to enroll on a trial. It's a state law. And so if there are barriers that you all are encountering, we have a team, like I said, Letty Marquez has helped spearhead a lot of this. For example, for a lot of our Kaiser patients, obviously a lot of care is done within the Kaiser network, but many clinical trials are actually not necessarily available through Kaiser. We have a great, strong partnership with Kaiser. We'll see patients, we'll get them on trial. They'll do their standard of care with their Kaiser doc. They may even do some of their imaging or other things that are not covered by the trial through Kaiser, but then they'll be able to have access to the drugs and other things covered through UCSD. So it is a state law in California. So I think there could be a path there.
Dr. McKay, wonderful talk. Thanks. Doug Berg here. Do you have any comment on the prospects for oncolytic bacteria or oncolytic viruses, perhaps in combination with CAR T therapies for prostate cancer?
Well, very good question. So they are absolutely being designed and developed. Actually, at this meeting just yesterday, Kevin Kelly gave an updated talk of a drug called AMG 509. It's not an oncolytic virus, but as you think about CAR Ts, it's a bispecific T-cell engager that binds to CD8 or CD3 cells, and then also STEAP1, which is a protein that is present on prostate cancer cells. And the data really looked quite promising. Just from his initial presentation, they were able to overcome some of the toxicity and CRS type symptoms, if you will, that were observed with that combination. So I think that there is promise. I'm actually literally took a picture of his slides, several slides. I think they had a PSA response rate that was in I think it was around 39% in the context of that study. Yeah, here it is. So yeah, right around 39%. So I think still early days. I think we need to figure out how to better deliver these drugs, quite honestly, is some of the cell therapy drugs, the CAR Ts, the bispecifics, they can be associated with engagement in the immune system in a way that could be detrimental. So, and oncolytic viruses, viruses are a way, in the way viruses work, they're a way that we can actually introduce specific DNA into the cell. So a CAR T is a re-engineered T cell. It's re-engineered and includes specific genes for a certain protein to be made by that cell that can have a negative effect on the cancer. And CAR Ts, the way that you get DNA to integrate into a cell, one of the easiest ways to do it in biology is with a virus. A virus can get DNA into a cell. And so some of these CAR Ts, they use a viral vector. The older ones did. But now the technology has gotten better where we use other things like a transposon, other things like that. But the way that you do, you know, genetic engineering, that's what we're talking about here. Genetic, I know it sounds, you know, the way that you do it is with the old school ways with a virus. It's how you genetically engineer something. But we still have a long ways to go with, I think, CAR Ts and bispecifics. Very good question, though. Thanks for attending, Doug.
Dr. McKay, thank you for your presentation and for your commitment to keep on learning. I wanted to know, how can we just get a hold of you? You know, how do we get a hold of you if we need help?
So if you want to, if anybody in the room desires a consultation to be seen and understand, I'm more than happy to see anybody and everybody. My administrative assistant is Iris Valencia. She's fabulous. Our new patient coordinator is Cynthia Alma. We can certainly get you in and kind of go through, you know, your case and go through your history and understand, you know, what makes sense. You're on the right track. Like, do we need to do something now? Do we need to do imaging? What are the clinical trials? So Jane Rachfalski is my nurse. She's amazing. For those of you in the room that have had the luxury of working with her, she keeps the wheels on the bus. She's my right hand and both my legs. I wouldn't be able to function without Iris and Jane. So, but I think Erin's got my email contact, and we certainly can get you connected in with our new patient coordinator. I generally don't like to give medical advice just over email without knowing someone's full history and knowing everything going on with them. I like to do it in a formal kind of way where we go through things and you get the best product, you know?
But I think one of the key ways to get a hold of you is just call UCSD, make an appointment to see you, yes?
Yes. Yes.
I know that
and
can be challenging in the past.
No, but if you know, like I said, if you message me, I can get you in touch with the right people, and they're usually right on top of it.
Great. Any other questions from anyone? What's that, Gene? Okay. Well, that was a fantastic presentation. You certainly are not narrowing down the field of treatments that we have to consider here. I'm amazed at how much is going on and really encouraged.
Yeah,
Again,
there's a lot of
sorry
hope.
for
Yeah, a lot of hope out there, a lot of cool treatments. And like I said, it's all about getting the treatments of tomorrow today. They're right at your fingertips.
And again, sorry about the audio problems today. Thanks so much. We so appreciate your time, and many of us will see you in February.
Awesome. Thank you all. Bye-bye.
Bye.